Welcome to The Explainer. We're diving straight into a high-yield clinical matrix designed to get you that perfect 270-plus simulation score. No basics today, just complex management algorithms, intricate mechanisms, and the exact traps you're going to see in acute aortic dissection and severe preeclampsia. Let's get right to it.
So, an acute aortic dissection. This kicks off with a catastrophic transverse tear right in the aortic intima. It's like a dam breaking. High-pressure blood just surges into the media, separating the layers and creating this false lumen. What's driving this longitudinal hematoma propagation? It's all about shear stress kinetics, specifically the left ventricular dP/dt. Clinically, you'll see a patient presenting with sudden, tearing anterior chest pain that literally radiates straight through to their back.
Now, you have an absolute mandate to stratify your diagnostics strictly based on patient hemodynamics. If your patient is hemodynamically stable, your gold standard first step is CT angiography of the chest. It's rapid, it's highly sensitive, and it's specific. But, and this is crucial, if they are hemodynamically unstable, do not put them in a CT scanner. That's a critical error. For the unstable patient, you strictly mandate transesophageal echocardiography, or TEE. You're often doing this right in the OR to quickly assess that proximal aorta and rule out pericardial tamponade. Take a look at this chest X-ray. It highlights the classic radiographic markers of aortic injury. Now, a film can sometimes look normal, sure, but you are actively hunting for a significantly widened mediastinum, apical pleural cupping, and the loss of that aortic knob. If a patient comes in with severe tearing chest pain and you spot this widened mediastinum, you've got to immediately suspect an aortic dissection and jump right into that stratified imaging protocol we just talked about. Okay, let's talk medical stabilization. There is an absolute pharmacological sequence here, and the order is 100% non-negotiable. Step 1 is strict heart rate control. You're using a rapid-acting IV beta blocker, like an esmolol drip, aiming to drop that heart rate below 60 beats per minute. This cuts down the left ventricular shear stress. Step 2 is blood pressure control with an IV vasodilator like nitroprusside. Listen, giving a vasodilator before you achieve beta blockade is a lethal error. It causes reflex tachycardia, which will explosively propagate that dissection flap. Don't do it. Let's evaluate the clinical variance using the Stanford classification system. Type A dissections involve the ascending aorta, regardless of where the initial tear started. These are absolute surgical emergencies. You're mandating an emergent sternotomy and repair because of the massive risk for coronary involvement, aortic regurgitation, and cardiac tamponade. On the flip side, type B dissections do not involve the ascending aorta. For these, you strictly manage them medically with that heart rate and blood pressure control sequence we just covered. You're only looking at surgery or endovascular intervention if they develop complications like end-organ ischemia or active rupture. All right, let's lock this down with an integrated assessment. You've got a 65-year-old male presenting with tearing chest pain radiating to his back. On physical exam, you notice asymmetric blood pressures in his upper extremities. His stat labs come back and his creatinine is 3.1 milligrams per deciliter. So what is the absolute best next step in diagnosis or management? A, CT angiography. B, transesophageal echocardiography. C, IV nitroprusside. D, coronary angiography. Or E, D-dimer. The correct mandate here is B, transesophageal echocardiography. Let's exhaustively break down why. This patient has the classic triad of a dissection, right? But he also has a severe acute kidney injury, highlighted by that creatinine of 3.1. That absolutely mandates you reject choice A, CT angio, because of the severe risk of contrast-induced nephropathy. Choice C, IV nitroprusside, is a lethal distractor. Remember, you cannot give that before IV beta blockers because of reflex tachycardia. Choice D, coronary angiography, requires contrast and is for an acute MI, which takes a backseat to a highly probable dissection right now. And choice E, D-dimer, it's sensitive, sure, but it lacks the specificity you need for definitive management, and it just wastes critical time. So TEE is the only safe, definitive diagnostic modality left for this patient. Module 2, severe preeclampsia and magnesium toxicity. So when does preeclampsia actually become severe? It happens at a very distinct hemodynamic crossover point. A systolic blood pressure over 160 or a diastolic over 110, recorded on 2 occasions. Mechanistically, we're looking at generalized endothelial dysfunction and vasospasm, which drives end organ damage. You'll see this manifest as thrombocytopenia with platelets crashing below 100,000. Elevated transaminases, signaling hepatic capsule distension, progressive renal insufficiency, or even the onset of severe cerebral or visual symptoms. The second a patient crosses into severe preeclampsia territory, your management immediately shifts to a rigorous dual intervention protocol. First up, strict blood pressure control to prevent maternal stroke. Your first-line agents here are IV labetalol, IV hydralazine, or oral nifedipine. Concurrently, and I mean at the exact same time, you have to initiate central nervous system protection to prevent eclamptic seizures. We achieve this exclusively through a continuous intravenous infusion of magnesium sulfate. Now, magnesium sulfate has a famously narrow therapeutic index. The critical toxicity threshold hits right between 7 to 10 milliequivalents per liter. At this exact level, the patient experiences a chronological loss of deep tendon reflexes, usually the patellar reflex first. You have to remember this loss of reflexes is the absolute earliest clinical warning sign of impending, life-threatening toxicity. Continuously monitoring these reflexes during the infusion, it's not optional, it's a strict clinical mandate. If you miss that loss of reflexes and serum magnesium levels climb past 12 milliequivalents per liter, the patient progresses to lethal respiratory paralysis and eventually cardiac arrest. So, if your patient on a mag drip shows absent reflexes or acute respiratory depression, your immediate intervention is twofold. 1. Instantly stop the magnesium infusion. 2. Immediately push the specific pharmacological antidote, IV calcium gluconate. This directly antagonizes the magnesium at the neuromuscular junction. When you're picking your antihypertensive, you have to evaluate the clinical variance based on the patient's existing comorbidities. IV labetalol is a combined alpha and beta blocker, which means it carries the risk of inducing maternal bradycardia and bronchospasm. Because of this, you must strictly avoid it in patients with a history of asthma or pre-existing heart block. IV hydralazine, on the other hand, is a direct arteriolar vasodilator. It works well, but its sudden hemodynamic shift frequently triggers reflex tachycardia. That can really complicate the clinical picture if the maternal heart rate is already running high. Let's put this protocol to the test with a third-order integrated assessment. You're evaluating a 34-week pregnant patient admitted for severe preeclampsia, currently on a continuous IV magnesium sulfate drip. While rounding, you notice her respiratory rate has plummeted to 8 breaths per minute and her patellar reflexes are completely absent. What is the exact immediate intervention required? A. IV flumazenil. B. IV naloxone. C. IV calcium gluconate. D. IV labetalol. Or E. Emergent C-section. The absolute correct answer here is C. IV calcium gluconate. This patient is showing classic severe magnesium toxicity, progressing rapidly toward respiratory paralysis. Let's exhaustively reject those distractors. Choice A, flumazenil, is your antidote for a benzodiazepine overdose. Totally irrelevant here. Choice B, naloxone, reverses opioid-induced respiratory depression, not mag toxicity. Choice D, labetalol, is an antihypertensive. It won't do a single thing to restore neuromuscular function and might actually worsen her hemodynamics. And choice E, emergent C-section? That is a catastrophic error. You must first medically resuscitate and stabilize the mother by reversing the imminent respiratory failure before you even consider any surgical intervention. Calcium gluconate is your definitive immediate lifesaver here.